I was recently shocked to discover that America's maternal mortality rate is the highest in the developed world. Our mothers are dying at rates 2 to 6 times higher than other G7 nations, even though we spend far more on healthcare. In the 1900s, the American maternal mortality rate was around 900 deaths per 100,000. Today, it's about 18.4, so we are way ahead of Abigail Adams and Ma Ingalls. That feels like good news, and it is, until you look at other countries. The United States is not just slightly worse for moms. When you look at the numbers, we have fallen significantly behind in caring for new mothers. Australia, the UK, and Canada, they only see 6 to 9 deaths per 100,000 births. Italy, Japan, and Germany are consistently below 5. And the Netherlands, Norway, and New Zealand have fewer than 3 deaths per 100,000 live births. All of that compared to 18.4. So, why are outcomes for moms so bad in America, the richest nation on earth? Why are our moms dying? And can we save them? When we drill down further into the stats, we start to see that not only is our maternal mortality rate alarmingly high, but it also affects American women in wildly uneven ways. One of the most striking stats, California has 9.5 deaths per 100,000, enjoying near Canada-level outcomes. Louisiana, meanwhile, reports around 42 deaths, making pregnancy about as risky there as you'd expect it to be for a woman in Brazil, Colombia, or Turkey. Disparities are even more shocking as you break deaths down by race and age. In August 2025, the CDC reported that Hispanic women enjoyed the best mortality rate, at just 11 deaths per 100,000 live births. Asians weren't far behind at 12.8, and white women died at a rate of 14.2, still high for a G7 nation, but far better than rates for Black mothers. They die at an astonishing rate of 40.8 women per 100,000 live births. If we sort deaths by maternal age, the disparities among groups are even greater. Women under 25 have predictably the best outcomes. Only about 9.7 die per 100,000 live births. Women 25 to 39 years old at about 16.7, but women over 40 have a rate worse than Black women, a whopping 48.8 deaths per 100,000 live births. Those numbers are particularly concerning in our culture of delayed childbearing. In 1970, first-time moms were on average just 21.4 years old. In 2023, the CDC data put that at 27.5, and it is still climbing. America's persistently high maternal mortality rates stem from a few common health complications, all of which have gotten worse in recent decades. The primary cause for all age groups is heart problems. In a 2019 study, doctors Coley and Molina identified a severe condition called cardiogenic shock that became more than 3 times more common among mothers between 2002 and 2013. Women who developed it had a 19% death rate compared to just 0.02% for women without it. Over 80% of these cases were linked to a pregnancy-related heart condition, and the vast majority of women who died from it died not during pregnancy, but in the year after they gave birth. Heavy bleeding, called hemorrhage, is responsible for 14.1% of maternal deaths in the United States. From 2006 to 2015, the rate of blood transfusions during childbirth went up 54% to a rate of 1 out of every 83 deliveries. Preeclampsia cases increased by 33%, and mothers with this high blood pressure condition face a 10 times higher risk of death. Rising rates of chronic medical conditions among women of childbearing age have also contributed to poor maternal outcomes. In fact, women with multiple chronic conditions face a shocking 276% higher risk of serious complications or death compared to healthy women. Other complications are non-medical, such as suicide and overdosing, which have also been on the rise as America's loneliness epidemic rages on. All told, the physical causes of maternal mortality in women are not unique to America. Women who die here die from the same causes as mothers in other first world countries. We just die more. Worse, we die much later in the childbearing timeline. Women in the developing world, Africa and Southeast Asia, die while giving birth. We die weeks or months later. Most people associate maternal mortality with the delivery room. Think Sybil in Downton Abbey or Melanie in Gone with the Wind. Maternal mortality doesn't just mean dying in pregnancy or childbirth. It also includes all deaths up to 1 year after giving birth. In America, 26% of maternal deaths occur during pregnancy, just 11% at birth, and the vast majority, 63%, die in that postpartum period, also known as the 4th trimester. As we know by looking at other countries, the majority of deaths are entirely preventable. A recent report from the CDC concluded that 60% of maternal deaths could have been prevented had the mothers been able to access care more easily. That's infuriating, but it's also the silver lining. We know there are solutions, and we know what they are. So why aren't we keeping up with other developed nations? The reason is maternal mortality is not a medical mystery. We have answers. It's a social action problem, prioritizing getting those answers to the mothers, their families, and their doctors. Feminists bemoan maternal death rates and blame the 2022 fall of Roe v. Wade. America's dismal maternal mortality rate is all because of a lack of abortion access? But the thing is, the end of Roe coincided with the steady improvement in maternal health. In fact, the maternal mortality rate fell 19.7% between 2022 and 2024. Not only that, but America saw a substantial increase in the number of practicing OBGYNs. According to Dr. Michael New of the Catholic University of America, researchers found the number of practicing OBGYNs increased by 8.3% in states where abortion is banned. Conversely, the number of practicing OBGYNs increased by only 7.7% in states where abortion was legally protected. If anything, the rise of abortions has led to more life-threatening pregnancy complications in the women who have them. For example, a 2003 article in the Obstetrical and Gynecological Survey indicated that a previous abortion increased the risk of placental previa by 50% and doubled the risk of preterm birth in later pregnancies. There is no evidence that legalizing unlimited abortion would save women's lives. Not to mention that the European nations with abortion restrictions, like Italy and Germany, have far better maternal outcomes than even the best American states, like California and New York, which have no meaningful restrictions on abortion. Women obviously aren't dying because they need more abortion. Instead, the system isn't serving mothers. They are dying because the care they do need isn't reaching them. The problem goes beyond the maternity ward. American healthcare is complex, bloated, and often indifferent to individual needs. And there are many factors, comorbidities, prevention gaps, poverty, but two areas clearly stand out: the overuse of childbirth interventions and a lack of consistent, high-quality postpartum care. As in every area of healthcare, hospitals and healthcare professionals are incentivized to make interventions, drugs, surgeries, and screenings, even when they are not strictly necessary. Hospitals and doctors are overwhelmingly rewarded not for good outcomes like a healthy mom and baby, but by how many services or interventions they log. Sometimes those interventions are necessary. The leading cause of death during or within the first 24 hours after childbirth is hemorrhage or severe bleeding. When this occurs, the threat is acute, and mothers need immediate aid to survive. The problem is, those life-saving interventions also carry risks. When interventions become less about emergencies and more about a menu of options, the childbirth process can resemble a waterfall of increasingly risky steps that, taken together, make birth more dangerous than it has to be. When it comes to birth, our system is often working against what leads to a healthy, safe delivery. Patience. Instead, we get interventions to help things along. For example, elective induction leads to more painful, sudden onset labor, which encourages more epidurals, which can lead to slowed labor, which encourages more drugs, which can lead to fetal distress, which often ends in a C-section. Any one of those interventions carries added risks to the mother and infant. But I think C-sections, the highest risk childbirth mode, provide the best insight into the cultural and economic factors contributing to America's dismal maternal mortality rate. Birth by cesarean saw a shocking spike in the United States from 1970, when just over 6% of births ended in C-section, until the mid-2010s, when it settled at 30 to 33% of births. For the last 10 years, over a third of all deliveries in the United States have been by cesarean, making it the most common surgical procedure in the country. The most common reason given on insurance claims for a C-section is fetal distress, which prompted the doctor to recommend the procedure in the first place. Much rarer is a true emergency surgery due to the immediate threat of hemorrhage or prolapse. C-sections carry increased risk of the most common causes of maternal mortality: postpartum hemorrhage, eclampsia, and infection. One study found that women who undergo C-sections are 80% more likely to experience complications. And for women aged 35 and older, the risk of severe complications is nearly 3 times higher. There is no reason to feel guilty about or to delay an emergency C-section. But the reality is that, like other so-called emergency interventions, C-sections aren't just done for emergencies. If they were, you would expect them to happen at similar rates with minor variation at all hospitals. But a 2015 Health Affairs study shows a dramatic variation in C-section rates across the U.S., from as low as 7% to as high as 70%. A Harvard physician found that hospital practices, not patient risk, are the strongest predictor of surgical delivery, challenging the assumption that C-sections are primarily driven by the health of the mother or baby. Dr. Neil Shah, assistant professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School, sums it up.
Getting a normal vaginal delivery requires patience. It's costlier to have a lot of really highly trained, expensive nurses and doctors waiting around for something to happen. That's essentially how childbirth works. You gotta wait, unless you don't wait, which is to do the C-section. So, I think that nuance is important, because I think some people think that doctors are sort of greedily doing a lot of C-sections so they can get paid more. It's not that. It's just that, in the trenches, when you're trying to make the decision between doing a C-section and not doing a C-section, a C-section will always be the easier way out for everybody involved.
In other words, C-sections and other interventions offer doctors, nurses, and even parents the path of least resistance. Add to that the massive financial incentives for choosing a C-section, even if they're not what most doctors are consciously calculating in the moment. C-sections cost about 30% more than vaginal births, and those profits are passed on to both the hospital and the OB. They fit the efficiency without liability culture. Between the psychological path of least resistance, convenience factors, and the path to profit, what should be a last resort emergency intervention became common practice. Some hospitals have found ways to slash C-section rates, and many individual doctors, OB practices, and midwives are actively resisting the overall cultural trend. Hospitals that successfully cut C-section rates focused on two key changes. First, they realigned financial incentives. Rochester General Hospital in New York State stopped paying doctors more for performing C-sections than vaginal births, removing the subtle pressure to go surgical and allowing physicians to prioritize outcomes over convenience incentives. Rochester also began routing low-risk patients to midwives and training their staff in labor positioning to encourage vaginal delivery. Signs were hung on first-time mothers' doors to remind staff that they often need more time. The government even stepped in. New York's Medicaid program began giving bonuses to hospitals, including Rochester, that made progress toward an 18% C-section rate. The program said it had paid out about $40 million so far. As a whole, these reforms reduced the most overused intervention and, by extension, the risk of maternal death. These changes need to happen everywhere, and especially in hospitals serving the most at-risk mothers. As I mentioned earlier, today most maternal deaths happen well after mom and baby go home together. From 1 week to 1 year postpartum, a weakened heart is the leading cause of death, followed by mental health crises like suicide and drug overdose. According to a 2026 report from the University of Pennsylvania Leonard Davis Institute, more than 40% of pregnancy-associated deaths in the state were tied to mental health conditions, with substance use involved in most of those cases. Even more striking, suicide and overdose deaths often peak within 3 to 9 months postpartum, long after most women lose regular follow-up care. In other words, precisely when the support system starts to scale back is when mothers are at highest risk. Add to that the fact that the majority of American mothers head back to work between 6 and 12 weeks postpartum, adding job stress at the moment when they are most vulnerable. The primary reasons they give for early return are financial necessity, lack of paid leave, and job inflexibility. As with all maternal mortality rate stats, there are wide disparities in these numbers, depending on age, race, and geographic location. Black mothers, especially ages 18 to 24, face significantly higher risks of death from homicide and non-medical causes, pointing to issues that go far beyond the healthcare industry. Lack of postpartum care and maternal rest have long been blind spots in American healthcare and family policy, and they are leading to preventable deaths. The silver lining? We know there are targeted interventions to improve mortality rates. For postpartum mothers, especially those struggling with sleep deprivation and depression, scheduling and then physically getting to a doctor's office can be overwhelming, if not impossible. The ideal course of action would be regular home visits for new moms, someone to keep an eye on her physical and emotional well-being. In Germany, which has a maternal mortality rate 5 to 8 times lower than the United States, postpartum care centers on consistent in-home support from a midwife. After discharge from the hospital, mothers typically receive daily home visits for the first 10 days, followed by regular check-ins for the next 8 to 12 weeks. The same midwife monitors the mother's recovery, supports breastfeeding, checks the baby's health, and screens for mental health concerns. Paid maternity leave for German citizens is mandatory for 8 weeks and extendable to 14. And both parents have a legal right to job protection, with around 65% government assistance for up to 3 years after the mother gives birth. Other G7 nations have similar allowances for mothers. Now, the American healthcare system will not be able to foot the bill for such a transformation overnight, but it is a goal worth striving for. There are measures we can take and other countries' practices we could imitate to tackle America's dismal maternal mortality rate. The question is, do we have the will to do it? I've talked a lot about the systemic causes of maternal mortality, but our broken system and perverse incentives are reinforced by what I call the root cause of maternal mortality. A twisted view of motherhood itself became the law of our nation in 1973 with Roe v. Wade. It infected the American healthcare system like a cancer, depriving providers, insurers, administrators, and sometimes even the women themselves of the will to make childbearing better. Abortion culture must be tackled head-on, even as we strategize on fixing maternal care systems and policies. Freedom of choice in law became freedom from responsibility in the culture. If women aren't responsible for the life growing inside them, then neither are our men, institutions, families, or doctors responsible for prioritizing the women who choose to give birth. Feminism has not concerned itself with advocating for women who bear children. In Planned Parenthood v. Casey, the Supreme Court even said that the capacity of women to act in society was based not on a common responsibility to support the mother, but on her freedom not to bear the child at all. The law is a teacher, and America learned the deadly lesson. We effectively castrated our social responsibility. As Erica Bachayaki put it, abortion forestalled solutions to the question of how women could fulfill their unique role as mothers while participating in the wider society. Needless to say, the delay on those solutions has been deadly. Instead of thinking about motherhood as a common good, we carelessly lumped maternal care into the same category as contagious diseases, neurological disorders, and cancer. But motherhood is not a pathology. Unlike infections or tumors or injuries, pregnancy and childbirth are signs that the female body is working the right way. Pregnancy, birth, and postpartums aren't things that any woman should have to girl boss her way through. Human reproduction is designed as a community undertaking. The gift of new life demands the response of all of us. We live in the richest nation in the history of the world. We have healthcare our great-grandmothers never dreamed possible. If we were committed to saving pregnant mothers, we could propose real solutions to address the root causes of our maternal mortality rate, starting with our attitudes toward motherhood. The good news is that pregnancy care centers, individual doctors, many midwives, and birthing centers are already making changes on the local level. Find them and support them. It is past time to transform our systems from treating pregnancy like it's cancer to supporting mothers like they're human. If you liked this episode, be sure to subscribe to the Loopcast. We bring you a new episode of The Deep every Thursday at 4 p.m. Eastern.